Hello, my name is Frank Oberklaid, and I'm a developmental behavioural paediatrician from Melbourne, Australia. I've had a long policy and research and clinical interest in early childhood and in mental health. So it's nice to bring both those things together. This will be a recording. I'm not with you in real time. Due to the marvels of technology, I'll be a long way away from my computer, hopefully, when you're watching this. So this will be a recording, and let's get started. I'll share my screen. So I hope you can all see that. So the first thing to say is that the language we use in child mental health is very important. And one of the reasons is that we've found, and I'm sure you found the same in your work, stigma is a very big issue for both parents and professionals. That our experience is professionals are often reluctant to raise the issue of mental health concerns with parents because of that stigma. They'll react in a negative and defensive way. We also find that the term mental health means that adults often default to mental illness. Mental health means mental illness, and therefore psychiatry, and therefore diagnosis, and therefore drugs. So mental health isn't a good word either. And we've been struggling with the language for a long time. We've tried some alternatives like social and emotional problems, mental health and wellbeing, social and emotional wellbeing. None of them work perfectly, but in Australia, we've landed on mental health and wellbeing. We never say mental health without adding wellbeing. And that's a much more strength sort of approach, whereas mental health is so negative. But what we refer to, I think we'd all agree, are young children's problems with self-regulation. They're active, they're intense, they have a low threshold of frustration, difficulty regulating emotions, problems interacting with peers and parents. Some young children have high levels of anxiety or social withdrawal, or they'll have behavioural issues that cause challenges for parents. And not that commonly, but importantly, we see more serious problems such as autism, infant depression, and so on. We know that child mental health is very different from adult mental health. I often say child mental health is a different country completely for a number of reasons that you all know. First of all, and importantly, children are not free agents. They depend on parents to bring them to professionals for help. Adolescents and adults can just go and seek help themselves. Children are dependent. And indeed, any interventions that we organise for children are largely through their parents. Many issues that lead to child mental health issues are predictable, and these are linked to developmental stages. There are identifiable risk factors. Having risk factors does not mean that a child is going to have these problems, but it just increases the chances. But importantly, from a policy and service delivery point of view, there are countless opportunities in early childhood mental health and child mental health for prevention and for early intervention. So we've tried to develop a very different approach in Australia to mental health in early childhood. First of all, our experience is that up until recently, child mental health problems has been seen through an adult lens. And the adult lens is diagnose and treat. And that's not appropriate clearly for children. We need a strengths-based approach, not just dealing with problems. It needs to be a developmental lens that includes not just the child, but the child and family. And we need to take into account the developmental stages and the milestones in the young child that's presented to us. And I don't need to say how important family factors are. Parents may contribute to the problems, but they are also the agents of change. And as I've already said, language is terribly important. And when we're dealing with mental health and wellbeing issues in young children, we really do need to take account of stigma. This is Mrazek and Haggerty's very well-known chart now, this whole half wheel, if you like, from promotion, prevention, treatment, and maintenance. And most adult mental health, in our experience, is really around this right-hand side of this half wheel. It's around treatment, diagnosis and treatment. What we're trying to do in child mental health, and these are the opportunities that we have that adult mental health doesn't have to the same extent is focus on promotion and prevention. That with young children, we can really make a difference in moving that pendulum away from treatment towards prevention. This is a slide that I developed a number of years ago in Australia to try and make that point, that when we're talking about child mental health, it's not just focusing on mental health tertiary services. It's not psychiatry and psychologists, because there'll never be enough mental health specialists, at least in our country. We really have to move that focus from tertiary all the way through to families, primary services, and secondary services. So we need to improve mental health literacy, because our research shows that many parents aren't familiar with the signs of mental health issues in their young children. So we have to improve literacy. We have to make sure that parents have ready access to well-informed primary services, nurses, doctors, preschool teachers, and so on. And part of the role of primary services is to contribute to educating parents. So we understand, I said before, that we need a developmental lens, a child and family lens to development. We all know the core concept of development, of course, that the way young children develop, the way humans develop, is shaped by this dynamic and continuous interaction between biology and experience, this transactional model of development, this dance between the genes that we're born with and our life experiences. An outcome is the result of these complex, ongoing, dynamic transactions between biology and the environment. So the child, represented here by the Constitution, evolves over time in a developmental sense, and parents, represented there by the environment, they evolve and grow as well. And the child has influences on the parents, and the parents have influences on the child. And we would define dysfunction, that is, children presenting with behavioral or mental health issues, as the abnormal outcome of this transaction. Something has gone wrong in this transaction between the child and the parents, that he or she is presented to you as having a mental health issue. We also know that you cannot separate cognitive and emotional and social and physical capacities. They're all interlinked. One affects the other. And we also know that persistent stress in that young child's environment impacts on the developing brain and increases the likelihood of these sorts of problems. And finally, we know that brain plasticity decreases over time in cognitive ability, in mental health, in any of the attributes. So it makes much more sense to try and prevent problems or intervene early. Biologically and economically, it makes so much more sense to get it right early on, to intervene early, than to wait until these problems become entrenched and then try and treat them. And this is represented in this slide by Bricker. The earlier we begin, the lower the cost and the higher the efficacy or effectiveness. The longer we wait, the cost goes up and the effectiveness goes down. And at least in our country and most other jurisdictions that I've been in, public policy is towards the right end of this continuum. That politicians and policymakers wait until problems become so severe and so common they can't ignore them anymore. Then they throw money at it at a time when it's very expensive and the evidence that we can fix those problems is pretty low. Apart from good nutrition and protection from infections and protection from injury, that is safety, the single most important determinant of the child's development is the quality of the child's relationship with parents and caregivers. So we know that when children grow up in a nurturing and responsive relationship, that builds a very strong foundation then for behavior, for learning, and for health. And of course, that's the whole rationale behind the nurturing care framework that WHO and UNICEF and the World Bank and others have developed over a number of years. We also know about risk factors in parents. This is a literature that's been around for a long time. None of these will be foreign to you. Poverty and its associations, substance abuse, mental health issues, tensions in the relationship, harsh parenting style, parental developmental issues of their own, housing, food insecurity, Indeed, any source of external stress poses a risk to parenting and therefore to the child. Now, there's no one-to-one correspondence between any of these and poor outcomes. It just increases the risk that there's going to be mental health issues. And we know from the research that any sort of adversity that impacts on the parents or caregivers has the potential to have a negative impact on brain development and act as a sort of predisposing factor or an increased vulnerability to that child presenting with mental health issues. We also know there are children's risk factors: prematurity, small for dates babies, developmental delay or physical disability, and something that I've been interested in my career, children with a difficult temperament, or indeed any temperament that's a poor fit with parental expectations and parenting style. These can all be risk factors. We also know in children there are predictable challenges based on their development. In infancy, we know that many, many infants are going to cry and have sleep problems and have unsettled behavior. And that's very challenging for a lot of parents. And that's often the very, very first sign of future problems. In the toddler, there are predictable challenges. The terrible twos, temper tantrums, oppositional behavior. We know from our clinical experience, and you do too, that many parents find this very, very difficult to control. They don't know what's happened to their infant, who's turned into this sort of monster that doesn't listen to them, that has temper tantrums if he or she doesn't get their own way. This is predictable. And then the preschooler, often oppositional behavior or difficulty with eating or sleeping, social difficulties, often with aggressive behavior or problems with self-regulation. These are all predictable stages of development. And we as health professionals working with children and families should anticipate that there may be issues around these developmental stages and be prepared to have these conversations with parents so they can have guidance and stop these predictable, normal developmental behaviors from turning into significant behavioral problems. So our approach to assessment, as I said before, we use a child development lens, which is dependent on the age and developmental stage of the child. It has to be child and family. And that's, as I said before, one of the differences between an approach to child mental health and an approach to adolescent or adult mental health. We identify child and parent risk factors, and those of you that are seeing these children and parents on a regular basis will be aware of these. Consider the use of the wellbeing continuum, the children's wellbeing continuum. I mentioned these in a couple of blogs that I've written recently that maybe you've read, and I'll talk about this in a moment. And then assess the nature of this mismatch between the children's temperament and parenting style. Parents have expectations often that the child should always be well behaved, should always do as he or she's told, should be easy to parent. And when that doesn't happen, because the child has a difficult temperament or a slow to warm up temperament, parents will find that often very challenging. And that's the first part of this cycle of dysfunction between the parenting style and the temperament or individual characteristics of the child. It's always useful to obtain information from other settings, from if the child is in childcare or preschool, ask the carer or early years professional, ask about other family settings, because that gives us important clues. If a young child is causing concerns only in the parental home, but is well behaved and causing no concerns in childcare or grandparents or in other family settings, that gives you some very important clues about the relationship between the young child and his or her parents, and provides very important insights then to guide your intervention and your guidance. And as I've said many times now, beware of stigma and focus on strengths and parenting successes. Even if you can see pretty clearly that the reason for the child's problems are difficulty with parenting, don't wade straight into giving them advice. Focus on the child rather than the parents. Here are ways we can make it easier for you to manage the child's issues. Supporting parents, I don't need to say, is just critically important. Build on the relationship that you'll have with parents. a trusting relationship, build on that. And the use of the continuum that I'll show you in a moment opens up space for conversations with them about any concerns they have, whether they're struggling, whether they're coping, etc. And as I mentioned in the previous slide, reframe the concept of parent support. Rather than focus on parenting and its limitations, focus on the child. Explain the developmental stage that the child is at and what the young child needs to thrive. So guide the parents into making it okay for the child rather than focusing on the parenting. This is the it's been renamed now. It's not the mental health spectrum. It's the child and wellbeing continuum. Healthy, coping, struggling, and unwell. It's very, very important because, as I've said a number of times, we want to get away from a diagnosis. We want to get away from deficits, from what's wrong, what's the problem, towards understanding that normal behavior is always on a continuum. There are days I feel great. There are days that I'm coping. There are other days I feel lousy. I'm really struggling. But that doesn't mean I've got a condition. For example, during COVID, you wouldn't be normal if you weren't anxious, both children and parents. And indeed, children go in and out of these various phases in the one day. So the use of this really opens up a conversation with parents. This is free and downloadable from a website. I'll get Issa to put this on a chat, and I would encourage you to download it and play around with it. We used this originally for children, but we're finding it's being used in many, many settings for parents as well. It just, as I said, opens up a space to talk to parents around, are they coping, are they struggling? Parents are much more likely to identify, yes, I'm struggling with a child, rather than self-reflecting on their parenting, or to say my child is struggling rather than say, I'm worried my child has an anxiety disorder or autism spectrum disorder. I guess the other thing what we've tried to do is conceptually to move away from focusing only on high-risk children. That traditionally, whether it's child protection, whether it's mental health, whether it's family violence, governments have focused on the hard end, the pointy end. And their rationale is if we've only got limited funding, we should invest it on those people that need it the most. Well, that sounds okay, but it's never worked because there'll never be enough resources. There'll never be enough trained professionals to keep on investing in this end, and more money isn't going to do it. So what we suggest is you need a really universal approach or a population approach where you educate or provide intervention services for the whole population, and we move that curve over to the left and therefore reduce the number of people in that high risk. And it's represented here as well. We shift the whole population curve into a lower risk category. So by doing that, we actually lower the number of children, the number of parents, whatever issue we're dealing with in that high risk pointy end that needs treatment. So in conclusion, we know that children pass through predictable stages and transitions that may pose risks to mental health and well-being. These are predictable stages. I highlighted them before in infants, in toddlers, and in preschoolers. We know that parenting plays a key critical role in shaping children's well-being. Children and parents develop together. We sometimes forget parents. We know that children go through developmental stages that are predictable, but so do parents. They develop together. So parents play a key role. Parents aren't just consumers of services, but they're the key change agents. They're critical partners with us in promoting children's well-being. And that's, again, a big difference between adult mental health and children's mental health. And that's why adult approaches, the traditional approaches, will not work with children. We know that adult and child well-being is closely connected, and we require a different language, a language of support and encouragement and well-being, rather than a language of diagnosis and deficits and problems. For those of you interested in policy, I really want to share some of the work we've done in Australia. I was co-chair of a national children's mental health and wellbeing strategy that was finished about a year ago and is now being implemented. I think we're the only country in the world to have a national strategy of this kind by the federal government. Notice these focus areas. We haven't talked about tertiary care or more mental health. We started with family and community because that's where we need to invest in resources, in parent literacy, in supporting parents. The service system is largely focused not on the tertiary care or hospitals or mental health institutions, but on childcare and maternal and child health nurses and pediatrics, education settings, and then evidence and evaluation. And there are 8 principles. It's the approach is child-centered, strengths-based. It's a universal system. It's not just focused on the pointy end. It's evidence-informed best practice and continuous quality evaluation. It's prevention-focused. We make sure that there's equity and access, so everybody has equal access, irrespective of their financial position. Early intervention is key, and it's needs-based and not diagnosis-driven. And this is the summary. In the last paragraph, I think, it proposes a number of actions that collectively represent a fundamental cultural shift in the way we think about mental health and wellbeing for children. A change in language that refers to a wellbeing continuum that supports early intervention, a change in status to give child mental health parity with physical health, a change to ensure access and equity, a change towards needs-based access to services, and importantly, a change in our collective understanding of the roles of families, communities, services, and educators. So you can see this is a major shift away from the way we've traditionally looked at mental health. So thank you very much. There's my email address.